Hello everyone, this is Scott Raffa on behalf of James Badu and Dr. Michael Wang here at the Department of Neurological Surgery from the University of Miami Miller School of Medicine. Thank you very much for taking the time to listen to our audio presentation on spinal osteotomies. We hope this provides some supplementary information to our chapter titled Spinal Osteotomies in the Yeoman's Text of Neurological Surgery. And if you hadn't had a chance to read the chapter yet, hopefully this will provide a much simpler and much more straightforward presentation of the information that's to come. Our presentation focused on the spinal osteotomy classification according to Schwab and others. This is also known as the SRS classification of thoracolumbar osteotomies. This is one of the first articles that we felt was most important to cite, and just wanted to emphasize this in our presentation. The spinal deformity postoperative imbalance article from Schwab, Patel, and others. This just highlighted the parameters that are meant to be achieved when making any correction to the lumbar or thoracolumbar spine. The SVA ideally should be within 50 millimeters. The pelvic tilt should be less than 20 degrees, and the lumbar lordosis pelvic incidence mismatch should be plus or minus 9 degrees. This should all keep you within that cone of economy that's described and shown in the upper right-hand corner of the slide. The two articles that were more historical but very important to understanding what's to follow were the original Smith-Peterson article and then a review article from Dr. Alberto Ponti himself. The above article is titled Osteotomies of the Spine for Correction of a Flexion Deformity for Rheumatoid Arthritis by Dr. Smith-Peterson, which is where the eponym comes from the Smith-Peterson osteotomy. And Dr. Alberto Ponti recently in 2017 published this article titled The True Ponti Osteotomy by the one who developed it. Their descriptions are key to understanding what's involved with each osteotomy type to follow. The first osteotomy type is the grade 1 osteotomy, which is characterized by a partial facet joint resection. Again, partial is the key word here. The alternative names are Smith-Peterson osteotomy, or SPO is the acronym. Other descriptors found in the literature include the opening wedge osteotomy, the extension, and or the chevron osteotomy. And this grade 1 osteotomy is detailed in turquoise in the A shaded color. As you can see, there's only a small amount or a partial amount of the facet joint that's resected and a very small portion, if any, of the lamina that is resected as well. To complete the osteotomy, the posterior elements may need to be removed and gentle compression is performed. These are additional pictures of the Smith-Peterson osteotomy on the left, as well as the Ponti osteotomy on the right, which is to foreshadow what's to come in the grade 2 osteotomy. The Smith-Peterson osteotomy figure on the left, again, shows a partial facet joint resection, and on the right, the grade 2 or the Ponti osteotomy, this is in the thoracic spine. This shows a more pedicle to pedicle type decompression, which includes partial resection of the posterior elements and lamina, as well as resection of the ligamentum flavum. Here are two other figures to again emphasize the significant difference that is between the grade 1 and the grade 2 osteotomy, also between the Smith-Peterson and the Ponti osteotomy. These figures are of a Ponti osteotomy or grade 2 Schwab classification osteotomy. Again, more so pedicle to pedicle. This involves the complete resection of the facet joints bilaterally, as well as a partial resection of ligamentum and partial resection of the lamina and posterior elements. On the right, you can see pedicle screw instrumentation, and the arrows depict the forces to compress and close that osteotomy. Now, taking a step back to review grade 1 versus grade 2, we want to reference our original graphic showing the shaded regions A versus A plus B. You can hopefully a little more easily see that a grade 1 or a Smith-Peterson osteotomy, again, is a partial facet joint resection versus the grade 2 osteotomy, shades A plus B, being a complete facet joint osteotomy resection involving the ligamentum as well as the posterior elements. Moving to a grade 3 osteotomy, we take a much larger step forward in the size and scope of the osteotomy being performed. The grade 3 osteotomy is very commonly known as the pedicle subtraction osteotomy. A grade 3 osteotomy extends the resection into the vertebral body. Specifically, a wedge resection is performed, leaving the disc spaces above and below that resection untouched. The posterior elements are resected in total at that level, again shaded in the A color, light turquoise, and the lamina is resected, the spinous process is resected, and a superforamen is produced as a result after the closing of that deformity. This is the picture that shows you the area of resection shaded in dark gray on the left, and then the forces used to compress that osteotomy. You can see that on the right, a superforamen is produced as a result of the closure of the bone-on-bone contact of the grade 3 or pedicle subtraction osteotomy. A grade 4 osteotomy involves the disc spaces adjacent to that resection. This is the original figure from the last slide. This would compare a grade 3 versus a grade 4 osteotomy. A grade 3 osteotomy is in light turquoise only, and a grade 4 osteotomy is shaded A plus B, involving the disc space above. Disc removal, again, characterizes a grade 4 osteotomy. This osteotomy resects slightly more than the grade 3 to include not just the posterior vertebral body and posterior elements, but also an end plate of at least one adjacent disc space. Alternative names have included the extended PSO, the PSO plus, or the bone disc bone osteotomy. In an article from the European Journal of Orthopedic Surgery and Traumatology from 2014, Osteotomies of the Spinal Column and the Resection in Pediatric Deformity, they described the bone disc bone osteotomy and 3 different types of the bone disc bone osteotomy. In all 3 types, there is resection of a disc space, but there's varying degrees of bone removal. In type B, which is centered in the PowerPoint slide, the type B bone disc bone osteotomy most parallels the grade 4 osteotomy. Focusing on the type B bone disc bone osteotomy versus the Schwab grade 4 osteotomy, one can see that this osteotomy involves both a wedge-shaped resection of bone as well as an adjacent disc space. These are very similar in fashion as a result and produce approximately 25 to 35 degrees of correction upon closure. The grade 5 osteotomy is also known as the vertebral column resection, the en bloc spondylectomy, or the complete vertebrectomy. A grade 5 osteotomy involves the total removal of a vertebral body, posterior elements, pedicles, as well as adjacent discs above and below the level. In the thoracic region, a grade 5 osteotomy also is accompanied by a rib resection. Some spinal deformities are not amenable to correction with lower grade osteotomies, and therefore the VCR does play a very important role in the treatment of severe deformity. For example, severe deformity could be a angular kyphosis greater than 50 to 75 degrees, or a hemivertebra with its adjacent discs involved. Spondyloleptoptosis, as well as previously fused and malaligned severe deformities, are also indications for a VCR procedure. The VCR is highlighted here in the light color A shade above. You can see a single level being resected, that being a total vertebral body, pedicles, and all posterior elements, as well as the disc spaces above and below. The type 6 osteotomy expands upon the grade 5 osteotomy, thus achieving the most coronal and sagittal plane correction of all the osteotomy types. Congenital malformations can lead to partially developed vertebra that may warrant a grade 6 osteotomy. In addition, tumors, infectious processes can lead to destruction of multiple adjacent vertebra, thus necessitating surgical treatment with a grade 6 osteotomy. Similar to a grade 5 osteotomy, grade 5s and 6s can be approached either in a posterior or a anterior-posterior combined technique. Complications are wide-ranging from relatively minor to life-threatening and can be variably defined in the literature depending on the definition of their complication. For example, their complication definition could range from surgically related to medically related, or could also vary upon the timeline involved, being short-term or long-term delayed complications. Surgical complication rates can be relatively low when performing grade 1 and grade 2 osteotomies. In recent articles, we've found that grade 1 and grade 2 osteotomy complications overall can be approximately 5% or less. And this is likely due to the less extensive bony decompression and less technical work that's required to perform the osteotomy. These osteotomies also lend more attention to the exiting nerve roots at the adjacent facet complexes. Moving through that spectrum of complication profile and percentile, grade 3 and grade 4 osteotomies have been associated with overall higher complication rates as high as 60%. Medically related complications may be due to significant blood loss, which can be greater than 1 liter per level, depending on the length of surgery. The length of surgery is also an independent issue and can be sometimes greater than 4 hours, lending a higher complication rate. The highest complication rates that we've seen in our literature review and to our understanding include the grade 5 and grade 6 resections, which include the eponyms, the vertebral column resection, or the multi-level end block spondylectomy. These resections can require a significant amount of decompression, and as a result can yield a significant amount of blood loss, up to 3 to 5 liters, depending on the literature reviewed. Complication rates of grade 5 and grade 6 osteotomies can reach up to 75%. Circling back to how and why these osteotomies are used is a much larger discussion. The indications are challenging enough, but the ability to understand the curve type, the degree of mismatch, and thus the osteotomy or combination of osteotomies, is a much larger discussion, but we did want to highlight this one article that did stand out to us from authors Daibo, Lou Lafage, and Dr. Schwab from 2014 from the European Spine Journal of Orthopedic Surgery and Traumatology. Osteotomies in the treatment of spinal deformities, which includes their indication and plannings. In the selection of the osteotomies, we found that a few key points that we wanted to highlight. You must consider the global alignment and have a very key understanding of all of the parameters necessary. The curve type plays a key role in deciding which osteotomy to use. This could be a severe kyphosis, this could be a flat back syndrome, this could be revision surgery or transitional level that would require an additional osteotomy type in opposed to others. One must also consider the thoracolumbar level or levels involved, such for example, one could consider a pedicle subtraction osteotomy if there's a need for that correction at the L2 or L3 level. In the thoracic spine, it's very challenging if unable to do a true pedicle subtraction osteotomy because of the presence of the spinal cord and the inability to compress and close the defect. In the thoracic spine, one may consider a VCR type osteotomy if it was warranted. Angles greater or less than 30 degrees, that's a question to be answered. If there is a deformity of any size less than 30 degrees, one could consider doing grade 1 or grade 2 osteotomies in a sequential fashion to gently and in a more sweeping fashion correct the deformity. If there's a need for 30 degrees or higher of correction, one could consider a single level osteotomy and treat that deformity with a pedicle subtraction. Curve type, not just the curve type, but the sweeping or angulated nature of the curve is something to be considered. For more sweeping curves, multi-level Ponti osteotomies could be considered. If there's a sharp angulated curve, particularly in the thoracic spine, a grade 5 osteotomy or VCR could be used to treat that deformity and correct it. And lastly, we wanted to emphasize that understanding the rigidity or mobility of the anterior column is very significant. If you're dealing with a patient with a non-fused mobile anterior column, you could consider multi-level SPOs or Ponti osteotomies, which are grade 1 and grade 2 osteotomies. If the column is fused and it's ankylosed, then one would consider not doing Ponti osteotomies and potentially entertain doing a grade 3 or grade 4 osteotomy at that level. Thank you very much.